So welcome everybody. It's a pleasure today to introduce our speaker. Our speaker is Ricky Frazer, who is a medical oncologist and consultant in Cardiff, and he specialises in renal cancer, skin cancer and acute oncology. There's so much I can say. I'm looking at his biography now and there's just absolutely loads. So I think I will, and obviously an expert in immunotherapy as well, because that's what he'll be talking about us today. Dr. Frazer does have a podcast as well. I don't know if you're going to mention that, but if you don't, I will mention it after, called Immunobuddies, and I'll give you the link to that if you like at the end of the talk. So without further ado from me, I'm going to pass you over to Ricky, who will tell us all about immunotherapy.
Great. Look, delighted to be here. Thank you for inviting me to speak. So look, my name's Ricky. I do a few things. I'm sort of a jack of all trades and master of absolutely nothing. And I'm going to talk a little bit about a few different immunotherapy bits. I'm going to talk a few concepts, but then it'll be more fun for us to have a discussion at the end. There's no stupid question, and I mean that in all sincerity. Ask me whatever you like, whatever you want to ask. It's much better to ask it than sit there and wonder. So I'm going to talk a little bit about what immunotherapy is, just so we're all on the same page. I'm going to talk a little bit about side effects. Now, that might sound a bit scary, but it's important that we know about them. I'm going to talk about some of the ways that I think we can empower our patients to give them the best possible chance with immunotherapy. And then I'm going to finish by talking about some of the things that I'm really excited are coming down the line. And again, if I'm still here at 9 o'clock, kick me off, because I'm meant to be going to see the script this evening at Cardiff Castle, and I will have missed the concert if I'm still here. So look, what is immunotherapy? And so I'm going to come back to the podcast a little bit later. If there's 8 podcasts that I think may be valuable to those who are new to immunotherapy. And so there's 2 podcasts called Immunobuddies Part 1 and Part 2, which are a very high-level overview of what immunotherapy is, specifically done for people who know nothing about immunotherapy, who haven't got a scientific background, to really get everyone into the same space. And then I'm going to talk later about 6 patient podcasts that we've created, which you may guess are specifically aimed at supporting patients who are having immunotherapy. So if you take nothing else from my talk tonight, have a listen to the podcast. Even if it's crap, it'll send you off to sleep. So use it as a sleep story. It'll be cheaper than the Calm app. So thinking about the immunotherapy, thinking about immune cells. So we've got lots of different immune cells in our body, and I'm not going to give you a talk about immune cells tonight, but I'm going to have to clearly talk about them. And I'm going to be primarily talking about T cells. So T cells in our body typically are there to kill viruses. So when we get a common cold, we will produce T cells. T cells will basically produce a sort of shower of nasty chemicals that will kill a viral cell. We also know it does that to cancer. So we also know it creates those chemicals and tries to kill cancer cells. The problem is it's just not very good at doing it. And so what immunotherapy is really giving the immune system a bit of a boost. Now, I promise this is one of the only scientific pictures I've got in the talk today, and I just want to walk through it very quickly. So those T cells are your white cells in your body, and the white cells, when we all have a spot and we pick it and we push out the pus, apologies if you're eating, that will be white cells that are coming out. Now, those white cells try and kill tumor cells. Tumor cells don't want to be killed. And so they basically put armor on the surface of their tumor cell. And that armor is called PD-L1. It's a protein, but frankly, who cares what it's called? It's just a protein that sits on the surface of the tumor cell. And when that binds to a different protein on the T cell, PD1, but frankly, who cares? It's just a protein. When those 2 things bind together, it's like putting a brake on your car. So it basically stops the T cell from being able to kill the tumor cell. And so I'm going to talk about immunotherapy today, And all immunotherapy are drugs, are molecules that either sit over the top of the PD-1 protein or sit over the top of the PD-L1 protein, remove that interaction, remove the break, and allow the T cell to kill the tumor cell. So just explain it one more time. We've got T cells that want to kill tumor cells. Tumor cells defend themselves by putting armor on their surface called PD-L1. That binds to something on the T cell and turns off the T cell. And so all immunotherapy are drugs that either bind to the PD-L1 protein or the PD-1. And if you bind to one of them, you stop them binding together, you stimulate the T cell, and the T cell can kill the tumor cell. And so that's what I'm talking about today. People like me make it sound more complicated than that because we like to dine out on it, but it really isn't more complicated. That's what we're doing. And the reason why I get so excited talking about immunotherapy is many of us, when we think about cancer treatment, we're thinking about chemotherapy, we're thinking about radiotherapy, but now we're thinking increasingly about immunotherapy in addition to things like targeted therapies, which I'm not going to cover this evening. And the nice thing about the immunotherapy is normally when you stop the chemotherapy, you stop killing the cells. The nice thing with immunotherapy, a bit like when you have your childhood vaccines, we're training the immune system to go around and carry on recognizing cancer cells if they develop and being able to kill those cancer cells long beyond when we're giving them the treatment. So we're training the immune system. It's a bit like training an army. Even if you haven't got war now, you're training that army. So if in the future there's war, we've got army to go ahead and fight for us. And clearly that analogy is more relevant than ever with what's going on in the world. Now, I don't want you to take anything from this slide other than to say there are now lots of different immunotherapy drugs across lots of different tumors. The 3 tumors that haven't really got good immunotherapy options at the moment are 1, pancreas, 2, prostate, and 3, sort of brain and sarcoma, so the rarer types of tumor. Most other tumors have now got immunotherapy somewhere in their treatment pathway. So where are we now? Well, I promise not to show any more data after these 2 slides, but this is just some data from melanoma. It's one of the tumors that I treat, and it's basically looking at the use of immunotherapy in melanoma. And if you had asked me 10 years ago how long someone with melanoma that had spread to their lung or liver would live, I would have said it'd be less than 12 months. But now this data, which is at 10 years after starting immunotherapy, even when it spread to the lung, the liver, or even potentially the brain, essentially just under half of those patients are still alive. And more than 3/4 of them are no longer on any treatment. And bearing in mind you're allowed to die from something other than your cancer, you've got about a 50-50 chance now. If you get stage 4 metastatic melanoma where it's spread, you've got about a 50-50 chance of being alive at 10 years. And that curve gets pretty flat from about 3 years onwards. So if you get past 3 years, you've got a really good chance of living a long time. But there's a downside. And the downside is that because we're stimulating the immune system, that same immune system can become active against our own body organs. And so I don't want you to learn all of this. That's not the aim of the talk. But if you think about any part of the body, your eye, your liver, your bowel, your kidney, any of those organs can become inflamed as a result of immunotherapy. So if you can think of the name of an organ, like liver, which we called hep, put the word itis on the end, which means inflammation, and you may get that side effect. So you could get hepatitis, inflammation of the liver, colitis, inflammation of the bowel, pneumonitis, inflammation of the lung. You name an organ, put itis on the end of it, and that is a potential side effect. And so we need to be really good at recognizing these side effects, and we need to be really good at managing them. Now, management is relatively straightforward as long as we know about it. And so when I'm in clinic, I always say to my patients, I did my clinic this morning, women are great at telling me what's going on. Men are a pain in my ass. Men never tell me what's happening. Women always tell me what's happening. And I can only sort out a side effect if I get told about it. And so I love looking after women. I can't stand looking after men as a rule because they sit at home for a week with diarrhea and I only see them when they become really, really sick. Apologies to the very good men in the audience, of which I think there's probably one. And so thinking about the modern immunotherapy pathway. So traditionally, and you know, this is a little bit, I guess, depressing, but traditionally people would get cancer, we give them some treatment, but most patients would die of their cancer. We're now in a different place, and that's why I love to give these talks. It doesn't mean that patients don't still die from cancer, they do, but we're getting better all the time at treating them. And so lots of my patients, when they see me in clinic, say things like, Ricky, I really want to fight my cancer. And I get what they mean. But what I always say to them is, look, I get paid way too much money to fight your cancer for you. Let me worry about fighting the cancer, but there's some things that you can do to give me the best possible chance. And I'm going to talk through some of them now as we go over the talk. We now know that the bacteria in your bowel will directly influence the chances of you responding to the immunotherapy. I'm that confident that this is going to be important that I've bought the web domain poopill.co.uk and poopill.com. And at some point, I plan to sell them for £1 million. Because I genuinely think at some point we will be treating people by giving them crapsules. And so again, apologies if you're eating, but I think we will be giving you poo from somebody who is responding to help you have the right bacteria to help you respond. And when that happens, I suggest that you buy your poo from me at poopill.co.uk. And the reason that's important is we now know that the more varied your diet and the more varied your bacteria, the better your response to immunotherapy will be. And so I don't want you to learn the names, but this is just giving a single bacterial species. It's called bifidum bacteria, but who cares? Alongside immunotherapy, and just giving the bacteria improves your response rate from about 20% to 60%. Just giving people the right bit of poo, the right bacteria. And so what do I tell my patients in the real world? I say, look, what you want to do is have lots of fiber in your diet. Fiber is food for good bacteria. You want a varied diet and you want as many fermented foods as possible because that diet will give your immune system the best possible chance of being able to treat the cancer. Equally, I tell my patients that in the first few weeks of treatment, if we can avoid antibiotics, we should. If you're unwell and you've got a nasty infection, you absolutely need antibiotics. If, however, you've got a bit of a cough or cold, you shouldn't have antibiotics in those first few weeks. It changes the bacteria in your gut. It reduces your chance of responding to the immunotherapy. And also, probably half of the people in the audience today will be on what's called a proton pump inhibitor. So a drug like omeprazole or lansoprazole. We give them out like Smarties. In fact, it's harder to get Smarties nowadays than it is to get omeprazole. There's really good data that says that PPIs, omeprazole, lansoprazole, reduce your chance of responding to immunotherapy. So in my practice, anyone who's on one of those drugs, I stop And if they convince me that they've got really bad acid problems, I switch them to a different drug called famotidine. So again, I try and avoid PPIs in my patients on immunotherapy. Now, one of the things that oncologists are notoriously bad at doing is we throw around words like everyone should understand them. So I just want to talk through 4 of those words, and then I just want to post you towards a podcast that hopefully will help demystify some of the terminology that we use. Adjuvant. So the word adjuvant is an add-on therapy. That's what adjuvant means. So if someone says that you're on adjuvant treatment, it means you've had your main treatment, which is typically surgery, and we're giving you a treatment to reduce the risk of it coming back. That's different to metastatic treatment where it's already spread. And typically we're giving the treatment with the aim of getting it back under control. The stage of cancer is how far it's spread. And stage 4 typically means it's spread to other parts of the body. Stage 3 typically means that it's spread to the lymph nodes. And grade basically tells us how aggressive the individual cells are. Now, when we started the podcast, which was about 2 years ago, I had lots of emails from patients and messages on social media saying, I'm trying to listen to your podcast, but they're way too complicated. Why have you not made any podcasts for patients? And all I could do is apologize because there's no real excuse for why we hadn't done that. So we reached out to healthcare professionals across the UK. I got one of my own patients who had developed a number of side effects to come on and basically interview us. And we made 6 podcasts. So if you're going to take nothing else away from today, just put Immunobuddies into Google and you can find patient podcasts on there. There's 6 of them. And if you want to take a picture of this slide, you're very welcome to. And this slide is basically, you can scan any of these QR codes and any of the questions that you can think of, hopefully we've answered, like, can I dye my hair? Can I have sex? Can I drink alcohol? All the things that most people don't really want to ask their cancer specialist, but will often go on Google to ask. And again, I'm very happy to share it with the team, and they can share it with you, whatever's easiest. But again, have a listen to them. You'll either learn something or it'll be the best sleep story you've ever had. But either way, you'll be a winner. And increasingly now we send letters to GPs in Wales when anyone starts immunotherapy, so that if you end up going to see your GP, they've got some idea about what immunotherapy means. Because again, traditionally, we've been terrible at helping primary care understand what we're doing. So in the final few minutes, I just want to talk about the future, and then I'm very happy to take any questions. There are lots of ways that we are now stimulating an immune response. And for anyone who wants some extra knowledge, there's podcasts on all of these topics. So oncolytic viruses are basically given a virus that's been inactivated. We inject that into a tumor. It breaks up the tumor cell. It releases lots of abnormal proteins and therefore stimulates your immune system. And so there's lots of now trials coming through showing that by giving these viruses, we can significantly improve people's immune response. This, I think, is one of the most exciting developments. We all know that COVID was a pain in the ass. We all know that COVID was horrible for so many reasons, as so many of us lost loved ones during COVID. The one silver lining from COVID is we've now moved on massively in cancer vaccines. And so we're now at the forefront in the UK of developing cancer vaccines to stimulate an immune response. And the data looks fantastic. So again, if you're interested, there's podcasts on cancer vaccines, which I absolutely recommend listening to. They're mind-blowing on what we're now doing in the cancer vaccine space. And finally, there's something called TIL therapy. And again, I'm not going to spend long talking about this, but in essence, what we can do now, and we're just opening this trial in Cardiff, imagine that you've got a melanoma on your skin. I can take some of those melanoma cells away. I can find the immune cells that are sitting next to that cancer. And because they're sitting next to the cancer, they by definition must have recognized the cancer. I can extract them from the body. I can send them to America. I can grow those cells up into the billions, and then I can give the body back those cells. They will go round the body like a magnet, find the cancer and start killing the cancer. It sounds like science fiction. It's really happening. And so there are so many ways that we are now harvesting the immune system to fight cancer. So the take-home messages from the talk today, and I'm very happy to take any questions. Immunotherapy has literally transformed the landscape of oncology. We've now got drugs that we're using in the real world. We're using immunotherapy across 16 different tumor types, but we're now finding more and more ways to harvest the immune system. Patients can now potentially live a lot longer using their own immune system to fight cancer. And the future looks genuinely bright at these new treatments that are coming down the line, which will directly impact patients in my lifetime, in your lifetime. And there is no more exciting time than now for oncology. I'm going to stop there. I'm going to stop sharing, and I'm very happy to take any questions.
That amazing. I'm so impressed with science and everything, and it's very positive talk as well. So thank you very much. I've got quite a few questions. Has anybody got any questions before I ask? If you want to put them in the chat or put your hand up, I'll unmute you. Well, whilst I'm waiting for questions, I've got some bit random questions. Why did COVID give us cancer vaccines?
Yeah, great question. So what we learned in COVID was terrible in lots of ways, but one of the good things about COVID is all of a sudden there were no rules anymore. We basically put all the rules aside and said we need to make a COVID vaccine tomorrow. And so within 9 months, we managed to create a COVID vaccine, which we could inject in leisure centers and other places just under the skin. And so what we realized is actually all the work we had done, if we took those same principles that we used for COVID and applied them to cancer vaccines, we could do the same thing. And so we can now give cancer vaccines in leisure centers and other settings. So it basically cleared out all of that process that we needed to do. Don't get me wrong, process is important, but it kind of allowed us to make progress, and it got everyone doing cancer. It got everyone doing vaccines across the world, which meant the technology moved on so quickly.
And also, just random, why do you send the cells to the States for your TIL therapy? Isn't there anyone who's in Europe?
Yeah, great question. So there's 2 centers in Europe. There's one in Denmark and one in the Netherlands. But these treatments are very expensive. So we're talking for 1 dose, but that's all you need is 1 dose. We're talking probably about £1 million. But we're talking about potentially curing people with 1 dose. So it's high stakes, and that's why at the moment it's very centralized.
Would you £1 million if you send it to the States?
£1 million per patient for the dose that might lead to cure.
Wow. So with that cost, with the acknowledgement of that cost, is that prohibitive at all in the NHS? Or
yeah, so at the moment it is, but there's so that's why loads of trials are open to give access to patients. But we may, I mean, it's almost a talk within itself. But NICE, who's the the people who decide on which drugs we can use, will likely negotiate a significant discount to that if it gets approved on the NHS. I don't know what that discount will be, but you know, you can probably divide that by 10 if it gets NICE approved.
Right, okay. So we've got a few questions coming as well.
Great.
Why doesn't it always work?
Yeah, great question. So there's a number of reasons why it doesn't always work. So if we think about pancreatic cancer, we know that pancreatic cancer has a lot of like a meshwork that sits around the pancreas. And so that fibrous meshwork stops those immune cells being able to get into the cancer. So we know that if you biopsy some tumors, they're basically deserts. They don't have any immune cells there. And so that stops the immune system being able to fight the cancer.
Are there any new immunotherapies for high-grade serous endometrial carcinoma that are strongly positive for P53 and ER?
Yeah, great question. So I guess the caveat to all of this is we have to be really careful about me talking about individual tumors, but I'll take the question on. So endometrial cancer, there is an immunotherapy. We know that P53 patients, P53 mutated patients are difficult to treat because P53 is difficult. But there is now a couple of immunotherapies that are licensed and NICE approved, but it will depend on what treatments you've had before. And so I would recommend a conversation with the oncology team.
Okay. And what can I do to increase my chances of it working? And I would like to add to that, what food, well, you mentioned the foods, but could you talk a bit more about diet as well? On top
Yeah,
of
of
what
course.
else can I do to increase my
Yeah,
chances?
no, of course. So the bottom line is the more varied the diet, the better. High fiber. Fiber we know is a good food source for lots of the good bacteria that we now know about. And so what can you do? Eat very varied diets. Fermented food is really good. The more varied, the better. The more colors, the better. You know, a typical, I'm going to call it a man diet, but we'll probably get bad feedback as a result. A beige diet is not a great idea here. And so the more varied, the more colorful, the better.
And is there anything, so I brought up the diet, but this was a general question. Is there anything else apart from diet that you can do?
Yeah, so we know that, I mean, again, I could talk all day about it, but we know that exercise improves your chance of responding to immunotherapy. So just simple, as much exercise as you can do, we know improves the number of the right immune cells that you've got. So eating well, trying to sleep well, trying to make sure that you're taking exercise where possible. All of those things that we ultimately know are good for us are good for your immune system too.
And it says, not so much of a question, but I was on Durvalumab treatment for 13 sessions and it's cleared all my cancer cells, but it gave me horrible side effects. So do you know how long it will take for these side effects to go away?
Yeah, no, great question. So side effects can be really difficult to manage. And so some of those side effects, depending on what the side effect is, can last months or even years. Most side effects are reversible, but not all of them. And typically the ones that affect the hormones of the body, so the hormones that your thyroid produces or the hormones that your adrenal gland produces, they tend to typically be permanent. So it very much will depend on the side effect. We know that some patients who get very severe side effects are also often the patients who do very well. And I guess that makes sense because the immune system's been stimulated and that's why you've had the side effect and that's why it's treated the cancer. So that's not all patients, and some patients who even don't get side effects still do very, very well. But that kind of, it makes sense that the more active your immune system, the more likely it is to treat the cancer.
And I've got a question from my melanoma and immunotherapy treatment. After 3 sessions, I had a seizure and it spread to my brain. How did that happen when I had treatment?
Yeah, no, great question. So, I mean, in essence, at any point, there may be cells that escape from any part of the body and get to the brain. Now, immunotherapy can work in the brain, but it's not as effective as it is in the rest of the body. So again, some patients, and we don't know why, but about half of patients won't respond to immunotherapy and half do, which means if you're in the 50% that doesn't respond, those cells can escape and get to the brain.
So have all your questions been answered? Does anybody have any other questions? And whilst we're waiting for further questions, I want to say, what do you see for the future? Is there anything exciting coming up in the next few years?
Yeah, I mean, I can't tell you how excited I am. So, you know, there are so many ways that we now can harvest the immune system. And bearing in mind that immunotherapy only really started 10 years ago. And so within 10 years, we've gone from no immunotherapy to half of melanoma patients doing really well. So over the next 10 years, I think we are going to get really close to being able to give patients a real chance, regardless of what their tumor is, by using their own immune system.
That is astounding. I love science. It's so impressive. Thank you very much. That's just packed with information and positivity. Yeah. So anybody else before we close up? I have to say, I'm an immunologist. I got my degree in 1985, my PhD in 1989, but I came out of mainstream immunology about 20 years ago, and I'm absolutely astounded at this massive change. It's just, I've also got something. I'm a firm believer in this form of treatment. Look forward to more advances. Absolutely, I absolutely agree. It's amazing.
What a lovely message to finish on.
Yeah. So, oh, yeah, we spoke about side effects, didn't we? Can I just ask, it's also a bit random, because I've been in the cancer arena for a long time, and people, you hear a lot about chemotherapy and how horrendous the side effects are. You mentioned side effects of immunotherapy. Is there, would you say that because immunotherapy is more targeted, and also because it's coming from within and it's not the whole body, would you say that it's less, or is it just something that you don't compare because of...
Yeah, no, that's a great question. So I would say that it's different. And so it's difficult to make a comparison. I would say that the difference, I guess, between chemo and immunotherapy is with chemo, nearly everyone's going to get some side effects. Everyone's going to get some sickness, some effects on their bowels. With immunotherapy, some patients will get no side effects. Some patients will get really severe side effects. And so it's different in the sense that with chemo, everyone will probably get some. With IO, there's no rationale for who gets it.
Okay. Well, thank you very much.
My pleasure.